Now that we've looked at some principles of ventilation, we're going to transition into a formal discussion of respiratory pressures. Understanding how atmospheric, intrapulmonary, and intrapleural pressures relate to one another is essential for explaining lung expansion, collapse, and pathological states like a pneumothorax. So first, what is atmospheric pressure? Atmospheric pressure is the reference point for all respiratory pressures. By convention, we assign a PATM of zero or value of zero, and all other pressures are described relative to atmospheric pressure. This simplifies the interpretation of airflow as air moves whenever intrapulmonary pressure deviates from atmospheric pressure. Remember, when we refer to a negative pressure, it simply means lower than atmospheric pressure, not absence of pressure per se. So, what is intrapulmonary pressure then? Intrapulmonary pressure is the pressure within the alveoli. So, the pressure inside the alveoli is intrapulmonary pressure. It fluctuates slightly around atmospheric pressure during quiet breathing, becoming negative during inspiration, drawing air in, and becoming positive during expiration, expelling air out. These changes are small, typically only one plus or minus 1 millimeter of mercury, yet they are sufficient to drive airflow because the respiratory system has very low resistance under low or normal typical conditions. Now, interpleural pressure is the pressure within the pleural cavity. It's always negative relative to atmospheric pressure due to the opposing elastic forces of the lung, that's inward recoil, and the chest, outward recoil. So this kind of common like push-pull that happens between the lung and between the chest keeps this intrapleural pressure negative. This negative pressure is essential because it keeps the lungs inflated and it prevents them from collapsing. It's mechanically coupled to the thoracic wall. So why is intrapleural pressure negative then? The lungs are going to naturally recoil inward due to elastic fibers and surface tension, while the chest wall tends to spring outward. The pleural space between them becomes sealed, slightly negative pressure environment. This balance of forces is what allows the lungs to follow chest wall movements during breathing. Disruption of this balance leads directly to lung collapse. And that's what we're showing here with transpulmonary pressure. This slide, you can see here all the different pressures we've defined thus far. We have atmospheric pressure here, which it gives us a base of zero. We then can go inside of the lungs and inside our alveoli, we have our intrapulmonary pressure, which at rest is zero. They're equalized. If this increases or decreases, it's going to drive air in or out of the lungs. So if it becomes negative, that's going to drive air inward. If it becomes positive, that's going to drive air outward, okay, for intrapulmonary pressure. Our intrapleural pressure is always going to be negative, and that's due to this recoil between the chest wall, the elasticity of the chest wall, and the tension in the chest wall and the elasticity and recoil of the lungs. And transpulmonary pressure is just the difference between this intrapleural pressure and intrapulmonary pressure. So remember, we can see our pulmonary and intrapleural pressure. So the differences between the two. So 0 minus a negative 4, and that gives us positive 4 millimeters of mercury as our transpulmonary pressure. So if we look at this kind of, almost looks like our cardiac cycle diagram. So if we look at pressure changes during inspiration first, during inspiration, contraction of our diaphragm and external intercostals is going to increase our thoracic volume. So our thoracic volume is going to get bigger. And then we can see this on this upper thing here with this big volume change going up. Our intrapleural pressure becomes more negative. That's this here. It's becoming more negative because we have a greater expansion of space that's occurring. That's going to pull the lungs outward as well. And as lung volume increases, our intrapulmonary pressure is going to fall slightly below zero, as we can see here. That's going to then trigger air to flow inward into the lungs. If we then look at expiration, during expiration, our inspiratory muscles relax and our thoracic volume is going to decrease back to baseline. When that happens, our intrapleural pressure becomes less negative. It's still negative, but it's becoming less negative because our lung volume decreases. And then when that occurs, when lung volume decreases, our intrapulmonary pressure is going to rise above atmospheric pressure, and that's going to lead airflow to flow out to normalize, to equalize things back to zero, again, back to baseline. Again, this intrapulmonary pressure or our alveolar pressure is really small pressure changes compared to our pleural pressure, for instance, or our volume change. But it's really that precisely controlled pressure change is what drives inspiration and expiration, specifically at rest. Now, I mentioned the defined transpulmonary pressure. Remember, transpulmonary pressure is defined as the difference between intrapulmonary pressure and intrapleural pressure. So, intrapulmonary pressure and intrapleural pressure. It represents the descending pressure across the lung wall, and it's the true force that keeps the lungs inflated. As transpulmonary pressure increases, lung volume is going to increase. Loss of transpulmonary pressure will lead to lung collapse. So, why does that matter? Well, transpulmonary pressure explains why lungs remain inflated even when intrapulmonary or alveolar pressure exceeds or actually equals atmospheric pressure at rest. It also explains why mechanical ventilation, pneumothorax, and surfactant deficiency dramatically can alter lung mechanics. This is one of the most important pressure relationships in respiratory physiology. So, this is showing again the elasticity of the chest wall pulling the thorax outward. Negative intrapleural pressure is affected by those opposing forces, and it's maintained because there's an adhesive force between the parietal and visceral pleura. Now, if a pneumothorax was to occur, a collapsed lung, air enters into the pleural cavity, eliminating this negative intrapleural pressure. And without this negative pressure, transpulmonary pressure falls to zero and the lung collapses due to its inherent nature to elastically recoil. So without this connection, this adhesive force, the lung could collapse. Importantly, the chest wall may expand outward, reflecting the unopposed outward recoil of the thoracic cage. So this is again showing lungs will collapse if. And so this is an example of a pneumothorax, lung collapse. So in tension pneumothorax, air enters the pleural space, but can't escape, it can't get out, and therefore interpleural pressure becomes positive, compressing the lung and shifting our mediastinal structures. This impairs venous return to the heart and can rapidly become life-threatening. Immediate decompression is required, and this is a clinical emergency grounded entirely in pressure physiology. Of note, my younger brother, he had a history of spontaneous pneumothorax, so spontaneous lung collapse that wasn't due to an actual puncture wound or stab wound. And so this occurred, he had these blebs on the surface of his lung, and these blebs they're like little balls essentially, and they would rupture. And when these blebs ruptured, they would essentially rupture open part of his lung space. Air would flow into this interpleural space, and the lung size itself would start to collapse. It would shrink. Sometimes it was very minimal, sometimes it was very obvious, very large pneumothorax. And so when this did occur, it was he needed emergency intervention. This occurred 3 separate times before they finally did a surgery. And the surgical procedure they did was a pleurodesis and a lobectomy. So they removed the lobe portion of his lung that was causing the blebs, the majority of the blebs. And then they did pleurodesis, meaning that they filled this intrapleural space with adhesive tacky substances. Unfortunately, it's talc plus gentamicin, which is an antibiotic. So that does have some inflammatory, causes. So there is some inflammation in this space, but he was having repeated tension pneumothorax that was spontaneous that he couldn't control. So this was the only way to prevent his lung from continually collapsing. And prior to this intervention, people would just die from this. He had to have a chest tube. It was a pretty extensive procedure, but it just shows that, this kind of relationship, this pressure relationship, he's young, healthy, he is very tall. So young, tall, thin AMAB individuals have an increased risk for this. It just shows the relationship between these pressure changes and pathology. Another component to consider is atelectasis. This is another pathology that we talked about pneumothorax, but in atelectasis, this refers to alveolar collapse, so collapse of the alveoli. And this happens without air in the pleural space. And it's often due to a surfactant deficiency, unable to maintain that opening of those alveoli. They collapse on themselves due to water surface tension from hydrogen bonding. It can also occur from airway obstruction or even shallow breathing, so not having taking deep breaths. Unlike a pneumothorax, intrapleural pressures will remain negative in atelectasis, but alveoli will collapse due to increased surface tension or lack of ventilation. Okay. Let's see here. We'll stop here, and then when we come back, we'll discuss a few other components regarding Boyle's law.